Good morning. My name is Francesca Valentine. I am a mother of a ring warrior, Marcus Valentine, but I'm also a registered nurse with a 40-year background in nursing, including critical care, which was a very important piece of the puzzle for his survival, as long as he survived from sickle cell disease. Marcus devoted his life to the understanding of others, uplifting his family and friends, and spreading awareness about sickle cell disease. He was born a full-term infant with ABO incompatibility. Testing for sickle cell disease way over 30 years ago is likely not as efficient as it is today. My husband was told that he did not have sickle cell trait. I was aware of my trait. Our first son is healthy. And at 8 months of pregnancy, my husband needed surgery. The physician called and said, "Mrs. Valentine, did you know your husband's 48% hemoglobin S?" That was a very heart-sinking moment for me, especially as a healthcare professional. Marcus was born and diagnosed at 6 months of age with sickle cell disease. That's about the time that you are no longer functioning on fetal hemoglobin, which doesn't sickle, and his own bone marrow kicked in and produced sickle cells. His early symptoms were, of course, severe anemia, blood counts as low as 4, life-threatening symptoms. One of the most life-threatening symptoms is sequestration. And again, your fetal hemoglobin is less likely to lose oxygen and then sickle. So at 6 months of age, he had his first sequestration crisis. This is important because it's a true medical emergency. The blood flows into the spleen, the sickle cells block the exit, and the blood cannot continue to circulate through the body, rendering the infant, if intervention isn't attained quickly, irreversible damage, even death. It is like having immediate rapid loss of blood to the circulation. And it's a medical emergency. Marcus experienced repeated sequestration crises until his spleen was removed at 18 months of age. The different types of crises are important to pay note to because vaso-occlusion is the most common, sequestration, aplastic, where your bone marrow just stops working and you no longer make blood, hemoglobin. Hyperhemolytic is very important, where you have massive destruction of your blood cells very rapidly. But the pathophysiology is very important because it is not, when we think of pain, everyone knows pain, but what pain is signaling is vascular inflammation, vascular damage, endothelial dysfunction, ischemia, reperfusion injury, and tissue and organ damage. That is a lifelong process, repeated insults and episodes, left unchecked, ultimately leads to irreversible damage and death. When Marcus was young, he always smiled. In this picture, he also loved animals. That was one of our first dogs named Fred. Marcus and his brother Kevin at one of the many hospitalizations. Despite all this, we let him do as many childhood things, and we figured out a way to do what people told us he couldn't do. He played Little League. He was a Tiger Cub. When you have sickle cell disease, it's a family affair. Many of our parties and activities were all surrounded by within the hospital picnic, hospital party, all the holidays, etc. When children are young, they are put in a safety net and umbrella of the pediatric system, pediatric major medical center. Everything is there, one-stop shop for care. Things change when you become an adult and have to navigate the healthcare system, likely at different locations because all specialties won't be under one roof. As a child, thank goodness we had access to pediatric major medical centers. By the time Marcus was 8 years old, he had already had multiple pneumonias, small bowel obstruction, splenectomy, cholecystectomy, salmonella sepsis, osteomyelitis, iron overload, acute chest syndrome, rendered him in respiratory failure and placed on a ventilator, and heart failure. The acute chest was his first complete volume exchange. By the time he was 3, he had his first pediatric venous port. By the time Marcus got to grade school, despite intense education for the school district and the nurses, his regular school nurse retired and there was a new nurse. Hindsight is always 2020. And I found out after the fact, he was in the nurse's office, just kind of being random and touching things and et cetera, told her he had black spots he was seeing. He was sent back to class. Subsequently, I got notified he was just being disruptive because he wouldn't spell. When we went in for an exam, it turns out he had had left and right frontal infarctions. Actually, his inability to spell what he learned in 2nd grade at 4th grade or so was a very silent symptom of a silent cerebral infarction. So he had strokes by then. By the time he was a teenager, we were deeply ingrained in the healthcare system, obviously. And I worked as an RN through all of this. Maintaining school and academics, always a family challenge. When he was younger, he had had so many blood transfusions, he was iron overloaded. And at the time, there was no oral substance to bind the iron. So he had 12-hour subcutaneous chelation infusions every day, adjusting his school schedule, adjusting after school activities. And it was a rigorous routine, but we involved him with his care. He could actually pronounce and know all the names of his medications even before he could do some of his kindergarten schoolwork. Having the 12-hour infusion, we never let it be a barrier, and we made sure that the school was a participant so that he could participate in everything kids his age would do. Despite all his complications, there was really no disease-modifying drug until later in his lifetime. Adolescence, there was no remission, there was no respite. He got transfused to prevent further strokes. Then the transfusions were abruptly stopped and he was placed on hydroxyurea. That came with its own set of complications and challenges. He developed the worst case of pityriasis rosacea that anyone had ever seen, so bad they wanted to put it in a textbook. He still made it to homecoming, though, and we made sure his suit covered all the way below his wrist, the only spot where he didn't have the lesions, and thank God, his face. By the time he was an adolescent through his adulthood, he had iron overload, chronic pain, avascular necrosis of his knee, avascular necrosis of his hip with femoral head collapse, blastomycosis, seizures, internal carotid artery blockage, temporary visual changes. We thought he was going to be blind. Restrictive lung disease, eventually requiring oxygen 24/7, repeated episodes of acute chest, cardiac cath to rule out pulmonary hypertension, heart failure was stabilized. He had an arrhythmia called the AVNRT, AV node reentry tachycardia, multiple hemolytic crises, priapism, and recurring leg ulcers. His leg ulcers were one of the most debilitating complications of sickle cell disease. Due to me being the type of nurse I was and having worked intensely with peripheral vascular surgery, podiatry, et cetera, I had access to treatments that maybe were not available to the general public. We were able to have access to a topical hyperbaric device for a number of months. I think that prevented amputation. It's not a conversation any mother wants to sit and have with their child, but we had to talk frankly about what he wanted. If amputation should be necessary, is that what you want? And he said, yes, he wanted to live. His wounds were so bad that they created sepsis. You're gonna also see a clip of a video. That is a sickle cell crisis post the first incision and drainage of his wound. The ulcers are common in the lower extremities, but they can be anywhere. Mind you, perfusion and reperfusion injury. So they are not a diabetic ulcer. They are not an ulcer from PV disease and smoking. They are unique to sickle cell disease, and they cannot always be treated as a diabetic ulcer or lymphedema ulcer or venous stasis ulcer. This is why he no longer went to wound clinic, because he would come home wrapped and constricted so tightly. Had I not been an RN and knew we should remove these and teach him to remove anything tight on his lower limbs, he would have set up a situation of limb loss sooner than, it would have been inevitable. He had many, many, many volume exchanges. And as a result of the wounds causing sepsis, the repeated sickling further led to the avascular necrosis of his femoral head. He couldn't have core decompression of that femoral head because he had back-to-back sepsis. He lost a portacath due to the sepsis. As a result, he had no femoral head, and it rendered him bedridden in our dining room for over a year. And it took 18 months of volume exchanges to close the wounds so that he could have the surgery to replace his femoral head, have his dignity restored, have some quality to his life back. And in terms of payer perspectives, we had to use Santal collagenase to debride the wounds topically. Also, he'd go to wound clinic to the podiatrist. He needed surgical intervention, not a traditional wound clinic. And he would endure the pain and suffering of these topical debridements, because to go to the operating room, as you'll see in one of the video clips, is the risk to come out with sickle cell crisis and then yet again require volume exchanges, risk of acute chest, risk of vascular collapse, so many risks. So we would use advanced dressings, collagenase, and then office debridement by a surgeon. Many times we were denied the collagenase, which was almost like a lifeline to prevent the need for an operating room, to prevent infection and sepsis, because without a wound that's debrided, the risk is high. And that was an exhausting battle, one of many, but that's what we'll highlight in the session. As a nurse mom, I was able to assist the team so we could send in the letters of need. And wounds are recurrent. At his time of death, Marcus had wounds open again. He had started on one of the disease-modifying drugs, and it was actually closing one of his legs without the need for exchange transfusions. There's a fallacy that you have to fail hydroxyurea to be prescribed another disease modifier. That particular fallacy angers me. At the time of Marcus's death, he had been on hydroxyurea for 20 years. We had to reduce the dose because it contributes to vasculitis. Marcus was on 3 disease modifiers actually. And on the day of his death, he was due to start the 4th. Every 6 weeks, he had to endure interjugular catheter from the cath lab to get his exchanges. That was the only way to close his wounds prior to the disease modifier coming to market. And at this point now, to protect his hip, he also had an allograft in his knee, which lasted 11 years. Had he had a traditional knee replacement, that would have been at risk to be seeded with infection once he developed open wounds. Open wounds on limbs with artificial joints put you at grave risk. We had to fight 4 years for that allograft and transplant of his cartilage. And he walked around on a dead knee for 4 years prior to. That was a fight with the insurance company. Cost benefit analysis is what helped me get approval for him to have home IVs and hydration, because the cost for us to do this at home, even with home health care, was far cheaper than going to an emergency room or clinic for IV hydration. So we did a lot to preserve quality of life. And I understand when there is a large volume of items that must come across desk for approval, you have to have a certain amount of emotional fortitude to live with this disease. It is very difficult, but you have to live in between. I was at a rare disease event a couple of years ago before Marcus died, and one of the women that ran the lunch said she wanted to highlight the living while everyone is searching for that cure. The complications of this disease, and I'm going to use wounds because that is what we're going to pull out of his life full of complications, was so demeaning. It required many things that were not covered by insurance. Every time the foot would remodel, you have a different pair of shoes, hopefully, until you got prescription shoes. The day he got prescription shoes, beautiful day. And we take shoes for granted. No one wants to, no one wants to put jewel bags on their feet and whatever you can fit over them and try to go anywhere. But if that's what it took to try to have some quality of life, Marcus was willing. For his therapeutic riding, we put the garbage bags over his legs, got cowboy boots 3 sizes too big, and off we went to the therapeutic riding stable. In many of the photos at the time he had wounds, you would never know what was covering his feet. But he always advocated and was a very firm believer that when there's a will, there's a way. And I was very grateful that the wounds didn't take his life, because he had so much more living to do before the cerebral hemorrhage took his life. So I hope the takeaway from this is that even though healthcare is a business, yes, decisions are businesses, payers are responsible for cost controls. We have to have responsible use of resources, et cetera. The resources are attached to a human, and they're attached to a human that would like to live with dignity and quality for as long as they can. Thank you. And thank you for watching. Lastly, Marcus's dream was to make a documentary. So I think there's going to be a video link for his documentary trailer. And then again, the other one is a link to an actual sickle cell crisis. He graciously agreed to be recorded in his most vulnerable positions in life, because we're a visual society. And if we don't feel it, we can't understand it. And hopefully through this visuals, it will change the perspective and also review of the physiology. It's very important for those of us with the ability and the knowledge and the training to understand that the physiology of sickle cell is not the physiology of diabetes, not the physiology of all the other illnesses. It has its own physiology, but the end results can create additional chronic diseases. So the sooner we mitigate, the longer and more quality of lives we'll give to so many. And in honor of Marcus, I want to thank you for your time. Good afternoon. The video you're going to see is of an actual sickle cell crisis, post-operatively after the incision and drainage of a leg ulcer. It is an actual crisis, and I would like to let you know ahead of time the content you may find disturbing. Thank you. The video you're about to see is the trailer for a documentary. Marcus in 2009 was a film student at College of DuPage. His dream was to make a film about living life with sickle cell. So this is the trailer from that film, and I thank you for watching.
My name is Marcus Valentine. I'm 25, and I'm putting together a documentary about something that I wake up with and live with every day.
I have a sick kid, and if I don't take care of myself, then something happens to us, what's going to happen to your sick child?
By looking at myself back then, as opposed to now, I probably wouldn't have thought I'd make it to 27. It may look like a regular school backpack that you put your books in and stuff. What people don't really understand is it's almost like James Bond, except I'm not fighting Russians, I'm fighting my body.
That's what's in my mailbox. This is all Blue Cross Blue Shield. This is just a little snapshot.
The long nights in the ER, the nights where you're up and off to the hospital, the fear of every crisis, not knowing if your loved one is going to make it out of the hospital this time. I am not fighting. I'm loving. That, my friends, that is the pump of choice. In worse condition than I left.
I'm so happy they're all here together. Kevin's here. You know, this is the moments that you live for this. Your whole family's here together. I knew Marcus would not survive this unless he was tough as nails, because I knew the road ahead was going to be rough, really rough.
I was born July 25th, 1983. And 6 months later, my mother and father were told that their middle child had sickle cell anemia, hemoglobin SS.